Oh, the first thing I have to do when someone meets me and being a psychologist is let them know I don't think their pain is in their head.
Oh, that's lovely. I mean,
Yeah.
what if somebody said that to every patient? What kind of difference do you think that would make for us?
I can tell you that in the interdisciplinary team that I see, it makes a huge difference.
Yeah.
It is literally suddenly, instead of it being us versus them in terms of patient versus provider, and as we talked about, I straddle both worlds, it really helps us all be on the same team. We're working together to fight the pain. And the person with pain doesn't own their pain. It's not who they are. They're definitely the one who has to report on it. It acts like a thief in their life, stealing all their vitality and their finances, their ability to feel like who they are and do what they want to do when they want to do it. But we can all work together to fight it. And I think that once we get that on the table, that the pain is not in someone's head, that it's not being caused by some psychic issue or psychological issue, then we can start getting down to brass tacks and dealing with biology and all the different ways we know how to deal with it, which is physical medicine, interventional medicine, physical therapy, and dealing with biology through the kinds of skills that I teach.
Hey there, and welcome to In Sickness and in Health, a podcast about chronic illness, disability, medical traumas, and everyday uncomfortable healthcare experiences. My name is Cara. I'm not a doctor or a medical professional. I'm just a person and a patient who really wants to talk about this stuff more. If you're new to the show, welcome. Nothing said on this show should be considered medical advice. If you're experiencing a medical issue, please seek qualified medical help. I know the system sucks, but I do wish you a lot of luck. Every person is different, even within disease groups, so none of my guests should be regarded as official representatives or spokespersons for their conditions. Please respect their very personal choices, and unless they ask for it, please don't make suggestions about treatments or lifestyle changes. As will come up again and again on this show, unsolicited medical advice is almost never not annoying. I am so excited to bring you this week's episode of the podcast. And for those of you living with chronic pain, I think you're really going to enjoy this one too. I talked to Jill Fancher PhD, a pain psychologist who lives with chronic pain herself. We talked about how she came to study pain, the devastation of being stuck in diagnostic limbo, stigma, existing in the liminal space between patient and provider, and the feedback loop between chronic pain, anxiety, and depression. And as a trigger warning, we do briefly discuss suicide towards the end of this episode. If you are in crisis or know someone who is, there's a list of crisis hotlines, chat lines, and text lines on the resources page, linked to in the show notes for this episode. This episode is pretty heavy in pain terminology too, and Dr. Jill was nice enough to help me out with defining some of those for you. This stuff is interesting, I promise, once you get past all the boring vocabulary stuff anyway. That resources page that I mentioned also includes a more detailed vocabulary list, and we'll go over some of them right now. There are different types of pain with different causes that are treated differently, but for the sake of brevity and not getting too dense, I'm actually not even going to get into that on this episode. But again, you can find more information about it on that resources page. Instead, let's start with the difference between chronic pain and acute pain. I'm actually going to use some of my own experience with pain to illustrate some of these points for you. As you may know, I have a connective tissue disorder called Ehlers-Danlos syndrome that results in frequent, full, or partial dislocation of my joints. This, as I'm sure you can imagine, is very painful, and those pains are acute pains. There are specific pains with an identifiable cause that generally resolves within the short term once that joint is relocated. But on the other hand, I have all kinds of chronic pain on top of that. More types of headaches than I can keep track of, pelvic pain of mysterious origin, soft tissue pain from the repetitive stress of my joints bending and sliding much more than they're supposed to, inflammatory pain in the cartilage in my chest and elsewhere, and other kinds of pain as well. All of these are present every day, and they've lasted for far longer than the chronic pain definitions that use a minimum of 4 to 6 weeks in duration. The most basic difference between acute and chronic pain is generally time frame, but it's a lot more complicated than that. All of those chronic pains continue to send pain signals to my brain, and every day I wake up feeling like I've been shoved through a meat grinder or beaten mercilessly with a baseball bat for mostly no reason. When my rheumatologist diagnosed me with secondary fibromyalgia, it seemed like an unnecessary addition to my laundry list of diagnoses. Like, do I really need to add to the list yet another poorly understood chronic condition that many people don't believe actually exists? Not really. But over time, as I've learned more about fibromyalgia, my pain, and how it behaves, I've come to understand why she made that diagnosis. The constant pain input to my spinal cord and brain over time has created a feedback loop, where as more pain goes in, even more comes out. Researchers are starting to believe that this may be why chronic pain has been such a tough nut to crack for so many. That regardless of how the pain started, this is a common pathway to how it wound up being chronic and so dang hard to get rid of. So let's talk a little bit about how and why we think this kind of thing happens. Some of the basics. Your nervous system is the network of nerve cells and fibers that transmits nerve impulses between parts of your body. This network coordinates voluntary and involuntary actions and transmits signals, like pain, to and from different parts of the body. Like other vertebrates, we have two main parts of our nervous system: the central nervous system, which is comprised of the brain and the spinal cord, and the peripheral nervous system, which consists mostly of nerves that connect the central nervous system to the rest of the body. When Dr. Jill refers to neurobiological systems, she's talking about the nervous system's interaction with the rest of a person's biology. Neuroplasticity is a buzzword you may have heard all over the place recently, but put simply, it's the way that our individual biology changes over time. Our neurobiological systems change to adapt to different situations. Whatever it practices doing the most over time, it will change to become more efficient at doing that thing. Which brings us to central sensitization. And it occurs in many people who experience chronic pain, regardless of what you actually call it. They think this is a big part of the puzzle at work in chronic pain syndromes like fibromyalgia and complex regional pain syndrome, or CRPS. Patients become more sensitized to stimuli, get more pain with less provocation, and can experience echoes where pain lasts longer than it otherwise would. Like when I bump into a door frame and it hurts for way longer and way more than it should. And it's not just pain signals that can get turned up all the way to 11 with central sensitization. For many chronic pain patients, other sensory stimuli can be amplified, including your sense of smell, which is called hyperosmia, your sense of hearing, called hyperacusis, sensitivity to light, called photophobia, and your sense of touch, which brings us to our next two terms, hyperalgesia and allodynia. Hyperalgesia is the term for increased pain from normally painful stimuli. Allodynia is the term for experiencing pain from an otherwise unpainful stimulus. With allodynia, even a gentle touch can be painful. Like the perfectly normal, not supposed to be painful thing that is often very painful for me is having hair grow out of my head. With hyperalgesia, the things that are supposed to hurt can hurt a whole lot more. Like when I bump into that door frame that might otherwise cause brief soreness for some people, for me, it will often make me feel like I got hit by a truck. Yes, it is exactly as fun as it sounds. None of this means we're too sensitive or exaggerating or that chronic pain is some failure of will. Our nervous systems are just doing what they know how to do best. Central sensitization is actually a normal thing for someone who is in pain all of the time. It's neuroplasticity at work. So now let's talk about how that pain is experienced. Dr. Jill uses 3 terms to talk about how we experience chronic pain: intensity, agony, and salience. Intensity is how loud the volume of the pain signal is. Agony is how much that signal bothers you. And salience is how important a signal is so that the brain devotes attention to it. She used the example of a paper cut, which is deeply unpleasant for anyone, regardless of whether you experience chronic pain. A superficial cut like that might be low in intensity but high in agony and salience because it is so bothersome and so often easily aggravated. In the interview, Dr. Jill mentions some specific areas of the brain that we know are linked to the experience of pain and are responsible for things like fear, attention, emotion, and executive function. I won't get into the specifics of those now, but you can find more details on the vocabulary list. It is these areas of the brain that she refers to as the agony circuit, which makes pain more than just a sensation like other sensations. Together, they make pain a torturous sensation, making it difficult not to think, I don't like this. I want this to stop. Why won't it stop? This isn't fair. And who among us living with chronic pain hasn't thought that before? All of that said, as we touch on in the interview, there's still very little known about chronic pain conditions, and this is only a tiny part of that. There's also a ton of research on the role neurotransmitters play in all of this. As usual, we know more and more about less and less, and we don't actually talk much about actual pain management in this episode. We pass no value judgments on the various treatments for pain, prescription, or otherwise. This is something that I hope to go more in depth on in future episodes. As the pendulum swings, more and more patients are being left without adequate or individualized pain management, and that's not something that I wanted to touch on only very lightly. So I hope you enjoyed this episode. I hope you learned some things about chronic pain, and if you've been feeling down on yourself for being in pain all the time, I hope this helps you understand that it's not your fault. If you want to learn more about Dr. Jill, her approach to pain, and find her book, you can go to masteringpainmethod.com. And you can find more stuff from In Sickness and in Health at insicknesspod.com and on social media at insicknesspod. Dr. Jill didn't set out to study pain. But now I'm going to let her tell you about how she learned pain is so important.
The first time that I realized that something was actually going on with my back was when I sneezed and something popped and I suddenly felt this great relief. And I thought, well, that's really odd, one, that a sneeze would make something pop. And two, gosh, something's really been nagging at me and it was great to have that relief. And I didn't think much of it, but then I noticed that I, over time, wasn't able to do the things I was enjoying to do. Like, I just couldn't quilt. I couldn't keep my arms out in front of me. And I was in grad school training to be a pediatric neuropsychologist, and I had to administer these tests, which require your arms out in front of you, like manipulating different tests and showing them different angles and sitting in these chairs. And within an hour of doing these testing, I could hardly sit still. I was squirming so much in pain. And I thought, well, this is just deconditioning. Listening to kind of the cultural norm here, I just need to buck up and get fit. And I saw a doc and she had me bend over and she's like, wow, you're really stiff. Let's get you to physical therapy. And so I was doing the kind of conservative measures and doing my best. And it didn't get better. It was continuing to progress and I was having more and more trouble. The physical therapist was getting very frustrated with me because every time I came in, like the side of my ribs that was being problematic was shifting. My collarbone the joint between my collarbone and my sternum stayed swollen and we couldn't keep it in its socket. It kept staying dislocated. And I was struggling to just do some basic exercises. If I'd lay on the floor and do like side leg lifts, my rib cage would spasm. Yeah. And I was just like, this is ridiculous. This isn't what I knew my body to function as. In my younger years, I'd played basketball and I'd really enjoyed that. And I just wasn't able to do what I used to do. And I was able to lose weight with mostly diet modification, and that was the aim of that was, I'd been told, hey, if you lose weight, you'll get all the burden off of those joints in your upper back, and you'll feel great, which is nearly 100% times a lie in my experience.
Yeah, I know a lot of people that have been told to lose weight, and then they do, and they actually feel worse.
That was exactly what I noticed. I felt incredibly worse. And yeah, we know that, for the person who's carrying extra pounds, the weight on the knees can wear them down faster. But losing the weight doesn't always alleviate the pain. What it does is it might make knee surgery recovery better, right? But it doesn't, I've not seen it alleviate pain, and it made it worse. But I lost weight and was able to get pregnant as we'd hoped. But during pregnancy, I felt fantastic. I felt great. I mean, I had complications. I had preeclampsia. I had swelling. I had all these issues.
Oh,
But
that sounds fun.
yeah, right. But my back didn't hurt, and I had energy. I was
Oh.
pregnant with energy. I mean, who says that?
Yeah.
And then I had my daughter, and she was 6 pounds, 6 ounces, and wonderful, and I couldn't pick her up. My hands became cramped and gnarled. I could hardly bend over to pick her up. My entire body was stiff. And it was at a consultation for nursing when the nurse who was helping us, the lactation specialist, said, you know, this pattern I've seen before, and I've seen it in rheumatological conditions. And I kind of just brushed it off. I was like, okay, whatever. I have a newborn to deal with. I can't hear that information right now. But as my daughter got older and I tried to get back doing things, I continued to get worse and worse and worse. This eventually led to an MRI and an MRI fiasco, where my MRI looks funky. I mean, my vertebrae looked like cauliflower.
Oh, wow.
And my ribs were building bridges to my spine and fusing all on their own. My bone marrow was swollen. Like my MRIs look funky.
Wow.
But the radiology report said I'd had an injury, and I was struggling to recover from that injury. So my primary at the time brushed it off. And I was lucky enough to have done my master's looking at children's brains on MRI, so I had just enough training to be dangerous. And I looked at my MRIs and said, I'm not comfortable with that answer. And I pushed. And I was, at one point someone said, well, you just want to have cancer.
Yeah, that's an interesting response. Like, if you want to have something wrong with you, like, no, there is something wrong, so I would like to know what that thing is.
Oh, Cara, you sound so reasonable. And I think at that point, I don't know that I was reasonable, to be honest. I was scared, right? I
and in a lot of pain.
Yes, and losing function and unsure what was happening to me. And at this point, still kind of deifying my medical practitioners and believing they had all the answers and could easily have all the answers too.
Right.
I didn't understand limits.
Yeah, you are a self-described science geek. I am as well. And, it's hard to, as somebody who is very respectful of and appreciative of science, realize the limits of science and the limits of practitioners and their knowledge.
That is one of the hardest things.
Yeah.
And even as I get into something, I'm like, oh, that answers this. And then I think, that opens 20 more questions. And I'm like, ah.
Yep.
But, to kind of make that long story short, it ended up in a vertebral biopsy ultimately.
Oh, wow.
And because my blood work has always been normal, but it was progressing. We were seeing this swelling in my bone marrow march through my vertebrae in my thoracic spine, and the bony growths continue. And so I was referred. I call it filleted open in my spine, and they drilled through 3 of my pedicles and took samples. And
oh, God.
First thing the doctor comes back and says, congratulations, you don't have cancer. And I said, I thought we already knew that. So what do I have? He goes, I don't know, but you don't have cancer. You can go back to grad school.
Oh, God. That's
and
helpful.
I'm like, yeah, real helpful. And I think that missing of the mark of what my needs were, what that diagnostic limbo is like for a person is missed by so many people. That is such a devastating space to sit in when you don't know what's wrong with you, and it seems to only be getting worse, and you don't know what to do to make it better.
And all of the people that are supposed to be helping you figure it out are telling you that, like, it's not a big deal, or you're fine, or, well, the good news is you don't have cancer, and that's not particularly helpful.
Not at all. And along the way, you start to see the truth in a lot of people around you, where they think you're being dramatic, or they think you're exaggerating, or hypochondriacal, or med seeking, or any of the other labels and dismissive and discriminatory ways people with chronic pain are treated. I experienced every single one of them down the line. And eventually I saw a rheumatologist who was like, really wish you'd seen me first. And I'm like, oh, I don't want to know this. And at that point, I was diagnosed with undifferentiated spondyloarthropathy. And I was told basically it was comfort measures at that point. The anti-tumor necrosis factor meds were just coming online, and they weren't FDA approved for spondylitis problems. And as I said, my blood work's always normal. My C-reactive protein, my SED rates, those markers of inflammation, always normal.
Mm-hmm. I'm the same way. I've had a lifetime of negative test results, and I get really excited when something actually shows up weird. And people think it's like the weirdest thing, but I'm like, you don't understand. I have felt terrible forever, and all of my labs say otherwise.
I can't tell you. I actually did the happy dance when my new rheumatologist, because I eventually stopped going to that person because we moved, but my new rheumatologist did an anti-CCP test, which is a newer one for RA, because I had now, 10 years later, I started having swelling in my wrists and my knuckles, my hands, my ankles, my feet. They were all hot, red, and swollen. And she was like, this looks like RA now. And she does this test. My RA factor and RF are all normal, ANA normal, but my anti-CCPs literally went off the charts. And I did a happy dance, and she's like, what? It's like, you don't understand. Yes, I was lucky enough to have a diagnosis, over 10 years ago with spondylitis, but to see a lab actually confirm something we were guessing at is, to know I have an autoimmune disorder and to have it documented is, it feels weird to say you're lucky to have that documented, but right. I see how many people don't get those answers and what a mind game that is to not have that documented.
Yeah. Because no one believes you.
Mm-hmm. And you can even start to doubt yourself.
Oh, I definitely did. Yeah.
Yeah. That doubt that other people pass on to you, and that, am I exaggerating? Am I being dramatic? And I think being a good scientist, that is a good question to ask of ourselves, right? We don't want to be clouded to any possibility. Mm-hmm. But wow, that can really lead you down a dark path if you're not careful. And to be present with the reality that you live within, and I think that's the challenge of having chronic pain.
Right, and where the balance is between acknowledging it and not letting, it's so hard to find a good way to say this because it has a lot of ableist connotations, but, not letting it stop you or whatever. Like, it's going to stop you, but how do you work within those limitations? How do you continue to live your life? That's a slightly less offensive way to put it, I guess.
It's hard to talk without the ableist script leaking in at times, isn't it? Because it's what dominates our cultural language right now. And I think most people still have this defensive reactionary posture when they are presented with less stigmatizing language, more inclusive language that the marginalized group wants to use. Mm-hmm. And so it's a fascinating process, especially with cultural concepts around chronic pain. The buck up meme, you just can't get away from that one.
Nope. No, and something that I ask a lot of people about is how their family deals with illness and how their cultural background might have influenced that. I'm fascinated by that because different cultures have different ways of approaching this stuff. I've actually stopped asking that question of most people because the answer almost always is it was just kind of suck it up and deal. So we're in so many different cultures that actually pervades quite a bit.
It does. And then you have the psychologist family, and my kids are PKs, which is the abbreviation for pastor's kid, psychologist kid, pediatrician's kid, and basically they're screwed. Mm-hmm. And my poor daughter, when she fell growing up, every time we'd applaud. And we'd say, oh, that was a great fall, but next time, gee, can you do a little harder? I don't know. And that was the best that I knew to do at that time. And she's grown up.
Why applaud? Mm-hmm. I'm curious, where does that come from?
So it came from this concept of masking the startle response of the parent.
Right.
And so it kind of grew into this. It was meant to be more funny, but over time we've definitely seen the effects, where her response to pain is very different than a typical response. And to the point where she was in a terrible accident and she broke her face and her nose and her hand, and she wasn't crying and she wasn't upset. And so the EMTs almost didn't take her by ambulance.
Yeah.
On the way, she ended up vomiting, had a pretty severe concussion. We didn't know things were broken at that point. And she's sitting in the ER, and they're like, well, we definitely, the CT shows your face and nose are broken. She's like, yeah, but my hand hurts. And they're like, yeah, can you move your thumb? She's like, yeah, but it hurts. And they're like, yeah. And I'm sitting there thinking, if this kid is not crying and she's saying something hurts, let's help her with that. Let's x-ray it.
Right.
They sent us home. They sent us home. And Monday morning on the phone with her primary, thank God she knew us. And she's like, we're x-raying that hand. Anything else she thinks slightly hurts, we're x-raying it. Because she doesn't have a fear response to most painful stimuli. And whereas my son, we kind of inadvertently then went another route because I was in a pretty severe flare-up when he was growing younger, in the kind of those formative 1 through 4 years. And so there was a lot of difficulty movement, using ice packs, and so he had a kind of different modeling of experiencing pain. And so he's had a lot more fear related to smaller things.
Interesting.
So while I won't necessarily speak to my family of origin, I'm in my current family, I'm definitely seeing how the microcosm of, and who knows, maybe that's their genetics too, and it just looks like it's the parenting impact.
Or it's a combination of both, which is more likely.
Probably. But it's fascinating to see kind of how they're both responding to pain differently.
Yeah, that is really interesting. And also, the gender difference as well is something that has definitely been talked about a lot. And you'll always hear women say, like, if men had to give birth or have their periods every month, they would be, just beside themselves and completely unable to deal with it.
Isn't that an interesting question? And I think that I don't think we'll ever know that.
No.
And I think that's the hardest part, is I think that there are some men with some situations that would do terribly and some who would do well. And just like some women, and you wonder about what's going on in their spinal cords and in their brains that amplify the salience or don't. For me, like, there are times when I'm in a flare-up, I can tell that I'm definitely hyperalgesic. I can tell that, smaller things hurt worse.
Yeah.
And then there's times when I had a terrible burn on my arm on a waffle iron. And it was clearly a 10 because I was actually passing out from it.
Oh, wow.
But as I'm passing out, I'm holding my arm and I'm saying, well, this is an odd sensation. This is a very different sensation. This is very different than everything. Whoomp. And so I think that even for a single person, we can experience pain in a lot of different ways.
Oh, for sure. For sure. When it comes down to it, because I am in that constant chronic pain state where I'm just so used to being in pain, a lot of the more acute pains that I will experience will, like, I can deal with it. And I think the wires in my brain are crossed a little bit where, like you were talking about with your daughter, of like making it falling down like a funny thing. I laugh hysterically when I get hurt. Like, I don't usually cry. I'll start laughing immediately. And even if I have like a really bad migraine, like, tears will be coming out of my eyes, but I'll be laughing, and people are like, are you okay? This is weird. What are you doing? And it's just, like, I just have like the strangest kind of reactions to acute pains.
Yes. And I think when when you've had chronic pain for a while, and any chronic illness, you do get funky wiring, because the more you try to cope with it, the more you're actually trying to do something that's unnatural.
Yeah.
It's natural for neuroplasticity to amplify the pain experience through spinal windup and brain changes, right? That's natural. When we try to mess with that by coping, by taking care of ourselves, by practicing different skills that can activate the different systems of our brain, like our natural opioid system, or deactivate the agony circuitry, or train muscle guarding, we're doing something unnatural.
Right.
And as cool as it is that we can do that, I think it does make for some funky reactions sometimes, like the person who can be in horrible, horrible pain and you don't see it.
Mm-hmm.
And it creates a secondary problem for them where they'll go into the doctor and have something very seriously wrong with them, and they're even more dismissed because they're coping so effectively.
Right. Yeah. You know, and as a person with chronic pain, our pain scale is so different than the pain scale that they present to us, like on a scale of 1 to 10, rate your pain. And it's like, well, my scale is probably like a 14 or 16 point scale, and it's completely different, you know.
Yep. Oh, that scale, especially the faces.
Yeah.
Because the faces combine two neurobiological systems, right? It combines the intensity of the sensory signal with how much it bothers you, which we know is part of the agony circuit, which is that amygdala, anterior cingulate cortex, prefrontal cortex. So it's the fight or flight and judgment and the torture of the pain. And so you could actually be at a really high intensity with low agony if you know it's going to resolve quickly.
Right.
Or vice versa. And so when someone shows me those faces, I'm like, oh, good God, can't do it. can't do it. I use a 0 to 10 scale that's focused on the salience of the signal. So how much attention does it grab, which is more correlated to the insula activation in the brain, which we know is related to salience. So for me, it makes a little more sense when I use it. But again, I personally don't believe that we can compare pain between people.
No.
I don't know what it's like to be in your body. You don't know what it's like to be in mine. And it's like, it's only relevant for me the way I use my pain scale.
Absolutely. Yeah. I mean, people's experience informs their pain, their brain and how it's wired informs their pain. You know, it's so different. And like you said, even in one person over a period of time or in response to different kinds of pain is completely different. And usually when I talk to my doctors about the pain scale, I'll talk to them, I'll use the term like threshold of like, well, you know, if it's like below a 5, I don't really notice it as much. It's just like, it's not, like, I can function, it's not a problem. I would prefer not to be in pain, but like if we can keep it below there, it's almost like I'm not in pain, you know. Yeah.
I completely agree, and that's exactly more or less how I approach it. Is if it's grabbing your attention for more time than not, and you can't use all the tools you have to get your attention away from it, then it's trying to tell you something important.
Right.
And at that time, it needs some kind of treatment, some kind of intervention.
Right. So you're a pain psychologist, and you actually are quite different than a lot of pain psychologists that I have read the work of or, you know, observed, in that you don't think that psychology can solve everything.
Right. I don't. I think it's a great tool. I think that it's one of the many ways that we can help the complex problem of pain, because we need to attack it kind of from all angles.
Yeah.
But I don't think it's the end all be all. I'm not going to treat my RA and my spondylitis with only psychological tools. I do take rheumatological medications for those as well.
Because you can't quite, you know, stop your immune system from attacking your body simply by being positive about it or, you know, meditating it away.
Right. I can help it, though. I can help on my medications. And that's, I mean, yes, we know that like engaging in activities that increase our sense of awe is anti-inflammatory. We know all kinds of fun things like that. Like there's certain, you know, nutritional profiles that can help reduce inflammation, that worry increases inflammation. So the more that we can manage worry can reduce inflammation. Great. That's all going to help. But it's not going to stop, you know, the different types of immune responses that cause autoimmunities, or for many people, they're chronic illnesses.
Right. Like there's no one cause, and so there is no one solution.
Exactly.
Yeah, the brain is powerful, but it's not that powerful.
Yeah, I mean, I'm not, I think that's where I'm careful about zealotry in
Mm.
any domain.
Yeah,
And I
that's
think that,
reasonable.
yeah, and I think whether it's the pill pusher or the chiropractic or the acupuncturist or the psychologist or the physical therapist, we can all really love what we do. Um, but if someone says their answer is going to cure you, run, run for the hills.
Yes.
Um, because it's never that simple. And at least I have not seen it ever that simple. And I should never
Hmm.
say never, but I have never seen it that simple.
Right. So, since you do straddle both worlds, you've written a bit about actually running into resistance from your colleagues. I'm going to
Hmm.
read this quote from your website. In some pockets of the medical and psychological professional community, outing my chronic pain can mean facing stigma, classification, biased interpretation of my character and behavior, and actual discrimination. Personally, I have faced judgment where someone has made assumptions of some ridiculous psychological origin of the pain, about being weak, boundaryless, hypochondriacal, covert messages that if I still have pain, I must somehow be incompetent to manage my own stress, and overt accusations of somehow wanting this, wanting to be sick, or wishing this upon myself. I mean, what a mind fuck that, like, you
Oh, that is
can't,
my term. Yes.
that, you can't even get understanding from your own colleagues who are supposed to be compassionate practitioners that are supposed to be treating this stuff, and even they don't trust you. Can you speak a little bit to that?
Oh, it is a minefield. It is so scary to present on specifically stigma and pain.
Mm-hmm.
Let's take that corner of being a provider with pain. I like to shed a light on the stigma. And because I'm part of that marginalized group, it's like, oh, well, of course she wants to. Oh, of course. And there's this patronizing patting of the head or a dismissal of the outcomes that I find
Uh,
because, I must be biased in my interpretation because I have pain. Well, of course there's biases. That's why you have to have multiple people on a team setting
right.
up your design. You've got to put safeguards because no one is free from bias.
And I think the worst kind of science happens when there's an assumption that you can be free from bias.
Agreed. Absolutely agreed. And so every time I give a talk or a training, the number one thing I have to practice is holding my space, not becoming defensive. I get Brene Brown in my head,
Mm-hmm.
not puffing up and not shrinking when I feel attacked. And so it takes a lot of self work and a lot of self discipline
And
to
it
manage
sounds
those
like
defenses.
you're keeping a lot of plates spinning in
Yes.
doing so.
Yes, and so that doesn't work so well when you're having brain fog and you're on
Yeah.
prednisone
I
and
was
you're
going to
losing
say,
your
it sounds
words.
exhausting.
And so at a recent training I was giving, I kept finding word finding issues
Yeah.
as I was aware of the glares or the glances that I would get from members of the audience. And suddenly a word would slip my brain because I'd have to check in with myself and am I saying something that's accurate or inaccurate? Hold this space, keep moving forward. And I don't know that many other fields in psychology face this quite as much. I know that there have been over the years, but in the current climate, pain is definitely a space where if you're presenting on it and you have chronic pain, it is difficult for everyone to always listen to what you have to say.
Yeah.
And yet it I think that's just highlights the work that we have to do in bringing awareness to the stigma.
Yeah. Absolutely. And shining a light on it, like you said, is just so important because if we don't do that, it only makes it worse.
Hmm.
So you get resistance also on the other side from patients who don't trust you because you are one of them. Can you talk a little
Absolutely.
bit about that?
Absolutely. I mean, I've had people come into my office and will literally say, well, you're a psychologist, so I can't trust you.
Which
Well,
is
you're
so
working with that
unfortunate.
doctor.
Yeah. I mean,
Mm-hmm.
did those people have negative past experiences with psychologists that kind of colored their view of it? Or are they coming from like a psychology is bullshit
You know,
place? Or,
it really, I think it's been in several different places.
hmm,
I think for some, it's they've been so brutalized
yeah,
by the stigma and discrimination they've already faced in the medical system because of their pain or in their private lives, that the idea of seeing a psychologist just confirms that everyone believes it's in their head.
right.
No matter what I say, I can't get past that. For others, it is how psychologists are presented in the media. I mean, when have you seen a psychologist actually function as a psychologist in any television show or movie? It's horrific in this field, you know. And I think the third is really people have had bad experiences. I think there are a lot of well-meaning psychologists, psychiatrists, mental health counselors, social workers, the whole range of behavioral health specialists who don't have training in chronic pain. And so what they do is they bring their biases into the room, and they do stupid things. Like they'll reassure somebody, well, you know, the disfigurement doesn't look that bad to me, you know, and you're like, huh, well, it does to me, and that's what's important, you know.
Right.
Or they'll, you know, someone talks about their fibromyalgia, and the first thing they'll ask them is do they have a past history of trauma.
Yep.
Oh, and you know, they might mean well, but they're perpetuating the problem and really doing harm when a person does that.
Yeah.
And so it's been part of my life's work and my business partner's life work to start training other providers in how to be informed and good providers with chronic pain.
Yeah. I'm trying to figure out how to phrase this question. Something about gaslighting patients and kind of trying to replace their experience with an assumed experience by the practitioner.
So there's a lot of different ways that this, I think you could go with that answer in that question. From the angle of somebody's had an experience of back pain, for example, and they read a book and they did what the book said and it helped them. And so therefore, if the patient doesn't get better when they read the book, they're crazy. They want to be in pain. This is psychological. You know, this is a victim stance that the patient wants to be in, kind of thing. And actually doing this enough time that the person starts to actually adopt some of those ideas. I've had to undo a lot of that I've seen people come in with. Well, I really must want to be a victim to this pain. Oh, okay. let's start there.
Yeah.
So I do spend quite a bit of time undoing. I think that I'm trying to think if I've seen anyone intentionally what I would consider true gaslighting, and I don't think I've really seen the truest forms of gaslighting. I usually see well-meaning people do a really bad job.
Yeah.
And it's not and I want to be fair to the medical community too, because they don't get the training, they don't get the time on this, and all they get is fear. They get fear that if they treat this person, they're going to be ridiculed. They have fear that if they prescribe an opioid, that the DEA is going to be knocking down their door.
Yeah, and that's like a whole other thing.
Yeah, right? And so you get into this fear-based medical interaction, and it's going to ring up that provider's defenses, and without the training to deal with that, what else are they going to do? And we'd want the best, and we'd want people to move beyond that and ask for the training and get what they need. But let's be honest, everyone is always overwhelmed.
Right. Interesting. So let's talk a little bit about how chronic pain and chronic illness can affect a person's sense of self over time, and how that can really kind of color their experience.
Well, I think I mentioned earlier when I talked about, you know, I think about chronic pain as this uninvited guest who moved into your house and decided to stay. And then they turned out to be that thief.
Yeah.
Then they steal everything. I mean, when you no longer can do what you used to do, the way you used to do it, when you used to do it, with the people you want to do it with, you don't feel like yourself. And And part of this is our society bases identity on what you do rather than
Yes.
who you are.
Yeah,
Right?
especially if that what you do makes money.
Yes. But even if what you do doesn't make money, I work with many parents who are the stay-at-home parent. And what they're doing is no less of a job, as we can all agree.
Yep.
But when they can't parent the way that they want to, or they need help parenting because something has gotten out of control, whether it's the migraine or the fibro, and they're in a flare-up, then suddenly they're just as much judged. Mm-hmm. And it's one of the things that I try to teach individuals, first and foremost, is the fact that you want to do what you used to do means the core of you is still intact. You are still who you've always been. It's just that you have a new set of limits. Now, you always had limits. We all had limits, right? Mm-hmm. I always use my basketball as an example. Prior to my spondylitis, I was 5'4.25". I'm now 5'3.25", but I was 5'4.25", and I'd play point, and I couldn't dunk a basketball to save my life. It just was not going to happen.
Gravity is a limitation.
Right. And, and there's just so much in my mechanics and my biology of my vertical leap that I could get going for me that just wasn't going to happen. And you know what? That was a limit I accepted. Mm-hmm. And I worked within that to do other things, like work on a hook shot and do some other things. With chronic pain, one of the ways that we can feel more like ourselves over time is to practice examining those limits and really acknowledging that they're there and not pretending they're not. Because goodness knows I love to pretend it's not there sometimes. I think we all do.
Oh, for sure.
And then with that acknowledgement, work to be creative to express who you are on the inside and those desires in new ways, as if those limits had always been there. So if you had grown up with these limits this way, how would you have expressed who you are, and what creative outlets would you have found?
Yeah, that's an incredible approach.
It's effective, and it's been effective for me. One of the biggest things that I have to work on is I am enthusiastic about a lot of different things. I have to keep my enthusiasm to intellectual pursuits rather than physical pursuits. Mm-hmm. And so rather than going hiking and biking and doing all these great Northwest activities that are around me, you know what? I'm trying to learn quantum mechanics. That's, where I can put that energy.
Right. Just redirecting it to something else that you're passionate about.
Exactly. But at the same time, there are still parts of self that do get morphed and shifted with any experience, right? I mean, that's what life is experience, interacting with that self, and over time it changes it the more we interact with something. And I wouldn't have done what I've done in my career with chronic pain if I didn't have it. I hope that I would have the same compassion and everything, but I don't know that I would have been as passionate about reading every article I can find and translating it and making it accessible. Mm. I don't know that, because I had chronic pain at such an early state in my academic career that it shaped the future of that. Now, I didn't plan to actually work in chronic pain. I had graduated, working in health psych. After working in peds neuro through my master's, I switched over to health psych for my doctorate. And I didn't study pain. It wasn't encouraged. It was almost like that field over there.
Which is so ridiculous. We have 1 in 2 American adults are living with a chronic health condition. About a third of American adults live with chronic pain. Like, why is this not more of a thing?
Well, I think at the time that I was in school, pain was the 5th vital sign, and so it was seen as, we've got this covered. Uh-huh. We've got it covered. We got analgesics, and they'll be our answer. We just haven't been doing these well enough. It was the pendulum swing. Mm. And at that point, it really wasn't in our face that we weren't doing chronic pain well. The rates of chronic pain have only been going up. And so we obviously, opioids are a treatment, but we need to treat the whole complex system for the person. And usually just blocking it doesn't address an underlying rheumatological condition, dysautonomia, other issues that we know can be present.
Right.
And so Yeah, so I think with that pendulum swing, sometimes we do learn some things in that process. But when I graduated and I opened up a private practice, we had a pain clinic in my community get shut down due to prescription practices, and I was flooded with referrals. And that's when I said, "Bring it on! These are my people. This is the work I love to do. I could see 14 people in a day and have energy because." Each person with chronic pain that I met filled up my cup.
Yeah.
And let's be honest, I have the best job for a person with chronic pain. I'm sitting for 45 minutes and then I'm up for 15. It's the perfect pacing you can do. I'm not doing any heavy lifting. The worst I have to do is type at a computer, but I can set up those ergonomics to meet my needs.
Right. And you have the balance of rest and movement.
I do. And I have the compassion of the people I'm caring for. When someone has chronic pain and they see I'm in a flare-up, they don't say, well, oh, you can't treat me today, you're in a flare-up. It becomes its own point of, how do we find what we can do that we love within the limits of our chronic pain condition?
Yeah. I think it would be so helpful if more practitioners understood truly understood, and you can only understand this through experience, the limits and how limiting this sort of thing can be. Because even if they know intellectually that chronic pain can be limiting, that unless you've experienced it, you can't really know what that's actually like.
Even to the point where when it's a acute pain, they're shocked by their reactions. In my training, we actually inflict some pain. And we have the providers who are there for trainings put clothespins on a sensitive portion of their body.
Yeah.
And the reactions are amazing. Everything from acquiescence to being the good student to anger and resentment and rebelliousness. And then they experience that for a while and the acute pain grows and you'll see someone want to take it off. And my first response is, oh, no, you don't get to escape this. You don't get to just take it off. This is forever. And then, then we walk them through some skills so they could see how they work or don't work, or how hard it is to attend to a skill when your attention's being drawn to a place that really hurts. And so we call it empathy building skills. But I don't think, and I don't think you can know unless you really experience the day in and day out. And unfortunately, that seems to be the song of all the different books you see out there is, right. I wish I'd known this when I was practicing before I had.
I see that all the time. And I'm like, no, duh. Yeah. I get full of rage when I read those articles and those books.
And at some point, I think I just want to start collecting every single one of those phrases. Yeah. And when we are training, individuals who work in the medical community, I want, here, do you have to become one of these ranks to get it? Mm-hmm. Do you have to? Because let's not make this happen. Let's figure out a way for people to get it before we have to get to this place.
Yeah. Yeah. Now, let's talk a little bit about kind of the feedback loop that depression and anxiety can create with chronic pain. I think that's something that's really poorly understood even by medical practitioners, that, this isn't what's causing the pain, but it can definitely exacerbate it. So can you talk a little bit about that?
First, I want to thank you for highlighting the fact that it's not causing it. I take a very firm line on that.
Oh, so do I. I was told my whole life that I was in pain or I was in discomfort or whatever because I was anxious. And it's like, well, I wasn't anxious before, but I am now. Thanks for that.
Yeah, so let's look at this timeline. And, I think that a person can have pre-existing depression, but I have yet to find that to be the generator of the pain.
Yeah.
So definitely. So we see the whole cycle of different kinds of depression, first of all, and different kinds of anxiety. In depression, you can have a person who has a pre-existing major depressive disorder that recurs on occasion, right? So they have a pre-existing biological system that is going to create a depressed state. We know that depression and anxiety are highly linked. There's often going to be rumination involved. Rumination being involved is going to increase the fight or flight response, which is going to increase systemic inflammation. So you have that going on. Now, you add a pain generator to this, and you already have an amped up system, so to speak. Okay? So you have this amped up system that's ready and primed to receive this pain signal. So let's just take the amygdala as one piece of this. The amygdala are grape-sized bundles of nerves on each side of the brain, and they're our danger sensor. They scan the environment for danger, and they're activated by threat, by worry, and by nociceptive signals coming up the spinal cord, so pain signals. And when the amygdala are activated from all these different pathways, it increases all of those experiences.
Right.
So we like to think of biology as being either sequential or simultaneous. It's both and affecting each other.
Right.
It's biology. Our lovely little logical brains don't always make sense of it.
Yeah.
So that's one path. Now here's the other path. The person doesn't have pre-existing anxiety, depression, and they develop a chronic pain, chronic illness situation. The pain itself can activate that amygdala, which is going to activate systemic inflammation, which is going to feed back to the body. We now know that inflammation is also part of a depressive picture, and that can amplify depression.
Right.
Take another angle on that. You no longer can do what you used to do. You're limited. You can't have fun. You're not getting that dopamine reward going in your brain. And you develop an adjustment disorder. As despicable as the process of getting a diagnosis can be when you're waiting and you're in that limbo space, the diagnosis itself almost always results in some form of adjustment disorder.
Interesting.
Now, then you get the question, is that really a disorder or if it's normalized? But I can tell you from my experience, when I got the rheumatoid arthritis diagnosis, as informed as I am and as aware of myself and my coping and having good self-efficacy, it still rung me for a loop because I had incorporated the ankylosing spondylitis as part of myself, as part of my awareness of the things that I deal with on a daily basis. Even though the symptoms had been present in my body for 3 years with the RA, having another label affected my sense of what I dealt with and what my challenges were.
Right.
And that created a depressed mood state and an anxious mood state.
Interesting.
And so many people can have an adjustment disorder with mixed anxiety and depression with one or the other. Both of them then augment that because they're going to activate that amygdala. They're going to send systemic chemicals through the body which amplify and accelerate the glutamate processing in the spinal cord. So both at the spinal cord level and the brain level, they can augment each other, share similar pathways, and that's why I say it's simultaneous, sequential, and interactive. And frankly, at the end of the day, when you treat the pain, if the pain is treated and there's leftover depression, people say, oh, then it has to be primary depression.
Right.
Not necessarily. Has the person also regained their sense of self? Have they regained engagement in the world? Do they have a social network again? So we I think being a good psychologist also means being a really good detective. And spending the time to look at timelines and listen to the person's experience of, like you said, well, I didn't have this depression before or the anxiety before I had the chronic illness, so hello.
Right. Or maybe I did, but it just, comparatively, the before and the after, after being put through that meat grinder, it's just, the difference was just so drastic.
Exactly. And I think we do see the magnitudes in difference. And so that feedback loop absolutely cycles on itself and cycles on itself and cycles on itself. And it's one of the reasons that I normalize the experience of wanting to suicide for a person with chronic pain.
Yeah, that's something important.
It's critical because the longer a person's fight or flight system, that amygdala and the whole fight or flight system is activated, their brain's going to be stuck in that desire to fight or flee. But with the chronic pain, if you can't escape it, over time and it's exhausted all the resources to try to escape, it's going to identify one final form of escape through suicide.
Yeah.
Now we have protective mechanisms in place, right? But those can be eroded the longer someone experiences it.
Right.
So the reason that I highlight fighting stigma is because the worse stigma a person experiences, the more discrimination and dismissal they experience, the worse off they are in fighting that fight against those suicidal impulses.
Yeah.
And that's part of building protective mechanisms, is having empowerment.
Right. And feeling so trapped, like if you keep running up against all of these walls where you're not getting the help that you need. Paul Gilmartin does the Mental Illness Happy Hour podcast, and he has talked a lot, he mentions this a lot, that, you know, people describe suicide as a selfish act. But the way that he sees it is like, would you say that about somebody who jumped out of a burning building? If they're trapped in a building that's on fire and they jump out the window, is that selfish? Because being trapped in a body where you don't have solutions and you're not getting the help you need, like, how do you not want to jump out that window?
And I've always loved his approach to that concept, because it really highlights how context changes how we judge a society.
Absolutely.
And I think that this is where we can find those points of intervention for a person with chronic pain, that there's so many different ways to deal with this. And for the person with chronic pain to recognize if those thoughts do start occurring to them, reach out for help. And if you're not getting it, get on to the online community, because we're out there.
Yeah.
And the online community can help point you to different directions if you do feel too stuck, or can give you the support you need at that moment of crisis. It's not a crisis line, and there are really great national crisis lines available as well. But when you're just starting to notice you're feeling more trapped and you don't know your way out, and you're feeling what I call that claustrophobic in your own body, that's when we need help. And that help can come in many different forms.
And also, it's important to get many different forms of that help, to approach it from many different directions. And you know, it's so hard to kind of advocate for yourself and pursue many different directions when you're at that point, because your emotional energy is almost completely drained.
I can't agree with you more. In fact, one of the things I had, a very well-informed patient recently asked me, she's like, you know, I definitely feel empowered. I know what to do. So what do you recommend when I go to the emergency room? And I said, bring someone else.
Yeah.
Because when you're the patient, you shouldn't have to shore up your empowerment.
Right.
That's the time to receive care, not to have to be the one in charge of your care.
Right. Yeah, that's a really good way to put that.
So that was the best that I could offer her at that point. I was like, yep, we need other people, and we need advocates. And there's in most communities there's advocates that you can find, and sometimes online we can connect with people as well.
Yeah. So you are in Washington or Canada?
I am in Vancouver, Washington, on the border with Portland, Oregon, actually.
I thought you were in Canada. I was going to ask you how you get paid, because I was curious about like reimbursement for your services. But
yeah, in Canada, it's very different for psychologists. Right. I do know that. But yep, I'm within the U.S. system.
Okay, that must be fun.
You know, here's an interesting thing. So I own a private practice. And I was not able to see the people with pain that I wanted to see over time, because most people are on Medicare and Medicaid. And so although I still own that practice, I actually no longer work there. And I work in a hospital-based outpatient center because I can see my Medicare and Medicaid folks. And what's so lovely about working in that setting is, you know, the mission of what we do is more important than the finances of what we do.
Right.
And so I'm grateful for that.
Yeah, that is awesome, because actually taking care of people isn't very profitable.
No, especially when it's the Medi reimbursement rates. It's not. And most people in private practice can't afford, they cannot keep their doors open if they accept those insurers. And so it was both for my self-care, just to have standard hours and health insurance for myself, and to see the people who fill up my cup and I enjoy working with. That's why I decided to move my actual daily practice to the hospital-based setting.
Well, that's tremendous. I'm so glad that you exist, because it means that maybe there are at least a handful of other people like you that exist out there, and are actually helping people with these problems. Do you want to plug your book or
Sure.
anything like that?
So, as you might be aware, I've written Master Your Pain. It is a workbook that really was a process for me of sharing the worksheets that my patients and I had developed over the years, and really getting to translate the science of what we know about biological self-management into everyday usable skills. So I hope that people find it and enjoy it, and remember that it's always about figuring out what works best for you, and that there's no one answer, and to keep your skepticism on high alert for snake oil.
Yes, that is awesome. That's a great way to end. Thank you so much for talking to me. This was fascinating and fun.
Thank you so much for inviting me, Cara. I really appreciate it.
And thank you so much for listening to this episode of In Sickness and in Health. If you are contemplating suicide or worried about someone who might be, please contact the National Suicide Prevention Lifeline at 1-800-273-8255, or find other more specific resources on the resources page linked to in the show notes. You can find more from us at insicknesspod.com and on social media at insicknesspod, and more from Dr. Jill at masteringpainmethod.com. Please rate and review us on iTunes. It helps other people find the show. And don't forget to be excellent to yourselves and each other.